growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner. Welcome back to The Lionhearted Dentist. Dentists that don't quit. Dentists that fight for the potential that you all have. Amazing potential in our chosen profession. So, one housekeeping thing, a couple actually. My April live surgical implant course, for the first time I ever can remember in 6 years, still has some openings. So if anybody who's taken a didactic series in surgical implant dentistry and would like to slide right back into treating patients live, you treat them, we monitor you, literally hands-on, in a very warm and receptive atmosphere. There is I believe a QR code I asked to put on this podcast. And if not, all you have to do is go to the Rasner Institute and we can hook it up. So a couple spots open in the April 2022 course, which is right down the road. Also, those of you that have followed such things, I have Dr. Rick Maron and Dr. Ihab Musa back to back in October. It's strictly didactic, but everything you need to know about bone grafting, GBR, soft tissue grafting will be covered. And I've taken both of them and they are excellent. I do this from time to time. I bring in people that I think are at the top of our profession at a particular time. And we get to spend some time together, and it's down in Vineland, New Jersey, where I practice. So let's get to this. The last couple podcasts, as you know, I have been speaking about case presentation. Why? Why? Because it's absolutely everything. Everything, if you're a dentist, your professional and your personal life revolves around patients saying yes to you. Do you not feel that? I could go on and just do the next 3 months of case presentation topics, and it would not be enough. So if you don't understand that when you walk into work tomorrow, next week, whatever you're doing has everything to do with patients saying yes. If you feel burned out because you're doing one crown on this patient and you're doing 3 operative direct fillings on another and they're missing teeth and it just feels random. Unfortunately, that's how a great majority of our industry functions, and it's not optimal functioning or dental care for our patients that way. And I know all you know this. And there's so much that goes into your patient saying yes, and we've been over lots of this in detail. What I've been covering for the last couple weeks is a different angle to this. And that angle is why your case presentations could be better. I actually said stink. Why your case presentations stink. And I realize that's not very politically correct. And I can tell you, I've had many ups and downs during a clinical year in my operatories. There are times when I am on fire, and I am so proud of the work I'm able to produce or put out there. And there's other times that I go back and I see something I did and I'm not proud. I really wish I could remember what happened on that given day. But I've done crowns that a year later were in recall and there's recurrent decay. Yep, me. I certainly have done implants that have failed. So a lot of it, we don't record what we do each day, so I can't remember. But I can tell you one thing that I'm almost never up and down on. And that is when I have that golden opportunity to meet a new patient. Get. You don't have to edit that, Josh. Me chasing the kitty with the water bottle spray. I didn't even spray them, guys, so don't get mad. No anti-Rasner mail because I'm cruel to animals, because I'm not. I would stop my car to move a box turtle off the road to the side of the road so he would be safe. I would swerve and probably run into a tree to avoid a squirrel. Big animal lover over here in the Rasner Lionhearted. So what I was saying is that I get excited 40 years later when I meet a new patient. I just do. And I love the moment of it. And I've never really spoken in depth about that part of it, but I do want to talk about why I think yours could be better. And last week, I talked about things like your branding wasn't clear enough, so you attract patients that have no interest in comprehensive care approach. Or maybe they're not screened enough and properly. You need to hear what I'm saying right now, because if it resonates, you don't know what I'm talking about, then you need to write to me. I have a lot of this in print. It's free, by the way. Or I can direct you back to a myriad of other episodes where we talk about it extensively. This week, I want to continue. Why your case presentation is not good enough and it could be better. You don't provide enough time would be number 3. So how much time should we provide? I generally provide an hour for myself beyond the paperwork that maybe they filled out online. Most of the time, to be quite honest, I think they do that in our reception room. And that's beyond them being charted initially. So here's how the flow is. When they finally get to the operatory, the first thing that happens is, and again, please write these down and reach out to me. I know I can increase your case acceptance. That is the whole point of the last couple podcasts. Because I know if I do that, you will enjoy dentistry much more. Going in and working on parts of a treatment plan, right? Until they're complete, where you now have a patient that's healthier. And you didn't get to do everything most of the time. I don't. And much of the time, I never get to that point. I had a patient in today. Here I go with Steve Rasner, Lionhearted sidetrack stories. This is interesting because you wouldn't expect me to share this kind of case acceptance story with you. So I had I'd say she was a 60-some-year-old woman on the higher side, maybe 68. And she left her last dentist. Now you can connect with this, I know, because she didn't want to go through all that scaling root planing stuff, and she let them do one quad, and she was out of there. Okay? That's my background, and some teeth were broken. So when I put her through our normal new patient channels, which included, obviously, her original phone call. By the way, she responded, because I remember this because it was today. She came to my office because of my radio ad, my live radio ad, which it's an oldies channel, and I don't want to use up our time tonight talking about particularly that ad, but that's where she came from, and it's quite a powerful source for me of very consistent patients. So these patients are listening to music from somewhere between the 50s, 1950s, guys, and 1980s. These patients are commonly 60 and above, which is beautiful. That is exactly what I'm looking for. And when I'm examining her, I can tell that she's never had any remote comprehensive care approach. I mean, I knew that in 5 seconds looking in her mouth. I also knew she didn't have particularly great work in her mouth. So, and she might have gone to the good old Dr. Joe dentist I allude to, who's kind of going through the motions, is not as invigorated as maybe he once was in dentistry. You've all seen work from good old Dr. Joe. He says, everything's fine. We'll watch that. We'll watch this until he retires. And don't get mad at me for it because I know it's a fact. He's checked out of dentistry. He doesn't want to completely sell or get out. He's probably incredibly well liked, way more than myself, by the collection of all of his patients. It's harder to be well liked if you're a comprehensive dentist because it costs more. And over again do I hear myself, including with this woman, saying to a patient that the most challenging thing about trying to be a good dentist is that in our industry, you can have abundant things wrong, pathology. And I talk just like this. And it doesn't hurt. It's asymptomatic. Sometimes I said to her, it's ironic that people kid about going to the dentist and a toothache and this and that. The truth is, it usually doesn't hurt. So it becomes our responsibility, if you're good, if you care, if you're engaged in your profession, to try to fix issues and problems when they're not out of control. I mean, how could that not make sense to almost anyone? And if you say it the way I'm saying it, and you believe in earnest that that's true, and how could you not? Then it really turns a lot of patients around. And when I looked at this patient, it took a lot of work because her mouth was such a mess. Yes, she needed quadrant scaling and root planing, but she had less than 20% bone loss. She was not going to lose her teeth. So I had to go back to that at some point in my treatment plan because I've told you that is not a negotiating part of the treatment plan. And I went back to her and I said what I just said to you. I said, listen, I know why you left your last dentist because I try to make it my business to know what's in your head. And I know you left because they wanted to do the scaling and root planing. And I'm going to come back to that with you. But first, we're going to look at what I like to call the have-tos. So the reason I'm telling you the story, guys, is that on my clock, that patient lost his treatment plan to lose 6 teeth, 3 of which are asymptomatic. They are crowns that, picture this in your head, that have been patched, crowns that have been patched on the roots, that have recurrent decay, that have furcations, that are, by the way, asymptomatic. And I said to this patient, I said, you're never going to lose all your teeth. If you move to an island and don't see a dentist for years, you're not going to lose all your teeth. What you and I have to focus on is getting your mouth healthier. That is where you're at right now. And I'm very aware that much of what I'm going to tell you to do doesn't even hurt you. Yeah, you know about the tooth on the right that you spoke of. So her treatment plan had no tooth replacement in it. She's actually going to be left with premolar to premolar on the maxilla and the mandible. And then a couple molars left. And by the way, they're wisdom teeth. So it's a very awkward, unbalanced. I didn't come close to being able to get into a balanced occlusion. This woman was a compromised treatment plan for me. And I don't feel wrong about it because her mouth had too many fires for me to try to rebuild a patient who left the last dentist because she apparently didn't understand scale and root planing, which is a very big part of this treatment plan that I put together today. And I was very clear. I said, not only do you need scaling and root planing, you're going to have to come back to us every 3 months, which the insurance isn't going to cover. And it's going to go by quicker than you can blink. Oh my God, I got to go back to Rasner again. I'm actually saying this to the new patient. But I smile a lot, and I'm earnest, and I'm sincere when I'm looking at her, because I am. And I said, you also need 5 or 6 fillings, I call them, restorations, so I can put those fires on. When I'm done, your occlusion's still going to be unbalanced. It's not going to be anywhere close to ideal, but at least it'll be a start with you. And I really do stand behind that. It's not my way or the highway with these patients. So that took a lot of time. That's why I gave myself an hour. That's why I give myself an hour. And I know that's a tall order for you guys. You got to remember, I don't get because we screen them on the first call. So I'm not working on 20 new patients a week doing this. That would be 20 hours a week. 6 patients a week, maybe 8, would be a big deal in my office. Screened quality patients that are at least going to let me speak to them about looking at their whole mouth, x-raying their whole mouth, examining them, and hopefully getting them on board. So you have to provide enough time. Remember my 120-day rule. You can always try one of these things for 4 months. 4 times 30 days is 120. You could always try one of these principles I share with you for 4 months, and if it doesn't change things for you, then abandon it. It's not going to bring your practice down, that's for sure. So far it's branding. I've said to you that your branding's not clear enough, and hence you bring in perhaps the wrong type of patients. And a good example of that, by the way, in my head right now, would be sending out a mass marketing that offered free consultations, free bleaching, free x-rays. Free is the worst word you could use in dental marketing. And yeah, you'd get an influx of patients and probably very little case acceptance from that. The second thing is you still have to screen because there's no guarantee that the ones will call you are really reading you clearly and understand that if you're going to come to our practice, yes, we want to look at your whole mouth. We're not a clinic. We're not going to extract your tooth and hope you come back. It's not what Lionhearted dentists do. Now I've said to you, you probably don't provide enough time. The next number says you may not have a fluid system. Our system is identical. Every single new patient. It is. The only thing that varies is who takes the x-rays and does the charting. Most of the time it's my hygienist, and sometimes it's a dental assistant. And I spent the last year in 2021 teaching him how to do a legal, bulletproof quality write-up. The next one may surprise you, and I'm saying reasons why your case acceptance isn't high enough, and that's that you have a one-dimensional personality. But you really don't. Some of you at work may, and some of you are better at what I'm alluding to right now than others. But it is important that I don't think it's being phony. I think it's a better way to relate to people. I've said it on other podcasts. There's 4 types of personalities, basically. And you can find this information in the book Non-Manipulative Selling by Alexandro, I think. Non-Manipulative Selling. It's a very old book, by the way. And I don't know if I'll remember them all, but they're thinkers, relators, socializers, and I can't think of the 4th one. Thinkers, relators, socializers, and drivers. And it's really true. It's an interesting chapter, even if you could download the chapter somewhere. And you have those people that work for you, and they're certainly in your family of patients. You're one of them. Okay? Some of us are thinkers. So it's important. And for me and many of us, I just naturally, think about it for a minute, I just naturally adapt to the person in my chair. So if it's a professor, you know the professor type, I'm probably a little more proper. I smile at everybody from time to time as I'm speaking. That's an important habit to get into. To be kind with your eyes and to smile. I'm serious. You can't walk into a room and be robotic with every patient, be monotone, lack passion, lack personality, and believe that you're going to have significant case acceptance because you're not. So many patients relate stories to me that the doctor never even came in front of me. He was in the room looking at my x-rays, taking notes, talking to me, but he was not looking at me. Now, I think all of you must be better than that. But communicating, being warm once in a while by smiling, having a little bit of levity and having some depth to your voice is not one way. Being excited, being, right? All of you have experienced that at some time in your lives. So why can't you bring that into the operatory? So I do believe, and I've worked with a lot of associates in my 40 years, and I've certainly gotten to know many, many dentists. And we have of course we have wide ranges of personalities. I think you got to be honest to yourself. Do you want more case acceptance? Are you a shy person? Perhaps you could work on your personality at home, on your shyness at home, because your shyness is very likely being misinterpreted as miserable. Sorry. The next two are pretty easy. You look tired or unkept. It's not a joke. And before every new patient, I go into my private office, into my private restroom, and I make sure I brush my teeth, and sometimes I'll splash water on my face. It's really not hard for me to get excited when I have a new patient. I do. I have one tomorrow or two. I get a report every night, and I think I have two tomorrow. And look, sometimes they are so hard to communicate with. I did a beautiful case. I mean, you gotta understand, I'm getting coached in notes from the hygienist that took the x-rays, or from Michelle, who, if I haven't told you yet, as soon as a patient is seated in the operatory from the reception room, Michelle goes in that room and does a repeat phone interview, kind of a one-to-one, we call it, interview, but in person. So I'm coached, and I was told about this one patient that, oh my God, he's tough. He is miserable, or my hygienist, I don't think I've ever heard her say too much in 10 years about anybody negative. She said, this guy's in a bad mood. And he was. I smiled. I did everything. I thought I finally warmed up to him, because 30 minutes into talking to him, I got him to start to speak. I mean, he looked at me like he hated me. Literally. That's the feeling I was getting. It wasn't pleasant. And he did not accept treatment. We blew him out of the office. I did connect with him at the end. You're not going to be everything for everyone, guys. Some patients, especially patients, I mean, this is the hardest thing about being a Lionhearted dentist, because I've encouraged you to do comprehensive treatment plans, which costs more. Well, guess what? Most of the profession doesn't do that. So guess what that means? It means most of your patients haven't spent significant money ever. So it makes us look greedy. And it's just not true. How could you not take a comprehensive care approach? Why would you not do that? Your office will turn into treating emergencies and hoping people will come back, and it's never going to happen. It's not how it works on a consistent basis. So I get pretty excited, even when I have challenging and tough ones in front of me. This I will tell you with no hesitation. You know how I know this approach is right? I'm serious. By the strong recall that we have, by how amazingly appreciative patients that I really don't remember the very first time we met, but I know that's where it started. I know that's where this appreciation for my kind of practice. And I often, when I say that to you, I often hear myself telling a patient, we're not the dollar store. And we're proud of that. We're a place where you can feel safe. Nobody's going to talk you into anything here. What we're going to do is educate you and give you options. I can give you more than one. I'll give you the best option that I would do. Or if you're my relative. That doesn't work for everybody. What I'm not going to do is give you an option for you to say yes. that I really don't think you'll be satisfied with based on my examination, based on our conversations. It's pretty real talk, man. And it's really how we all should aspire to. I'm not sure where it came from with me, but I know it's the right thing for patients, whether they say yes or not. And then the last note I hear of my 7 ways to make your case presentation better, getting more yes, is that you lack eye contact and warmth. And that's hard for some of us. Even myself sometimes. It's easier not to look a patient in the eye. It's a really important part of patients trusting you. And I'm gotten much, much, much better at it. And warmth. If you don't know how to generate warmth, I think you can. YouTube is a great educator for us all. There's not a subject you can't come across. So, again, I know this is the 3rd podcast in a row where I've spoken about the angles of case presentation. It's because I think it's the number one thing that could change your 2022 onto the best year you ever had. I hope everybody's enjoying this. Reach out to me. I love to hear from you guys. I'll see you next week on the Lionhearted.